I'd like to thank the PCRI for giving me this opportunity to speak once again. For me, it's a joy to be invited back. As all of you know, the intent of this Prostate Cancer Combat Manual series is to provide information to help guide patients through their own personal battles with prostate cancer. I also want to thank those of you who have written to me with your kind and personal stories pertaining to how you've used these lectures to improve your own cancer care. For me, nothing is more precious and gratifying than knowing that I've been able to help some of you no matter where you are. I do deeply feel the anxiety and the pain that many of you are dealing with as you go on your personal journeys with prostate cancer. Simply letting me into your life is indeed the greatest honor and privilege I could ever envision. As always, I need to mention that Mayo Clinic and I have received licensing payments for PD-1 and PD-L1 immunotherapy related technologies. Before I jump into my presentation, I just want to say that it might be useful for some of you to review my previous PCRI lectures, which are posted on YouTube. Some of these lectures might help you better understand what I will be discussing during today's presentation. You can find these previous lectures by simply scanning the QR code that is provided on this screen. These are some lyrics from one of my favorite songs ever, Shine On You Crazy Diamond, from Pink Floyd's 1975 album, Wish You Were Here. To me, these lyrics convey the sentiment that you are the only person who really knows you. Therefore, I think you should take charge of your own medical care whenever possible. So virtually every year, exciting new agents and technologies are being introduced for the management of prostate cancer. In general, I think this is a good thing. Yet, despite the torrent of new and shiny ways to treat prostate cancer, I still get the sense that many men and their families feel as if they're racing blindly through a gauntlet of palliative treatments towards a very uncertain future. For the average patient, their treatment journey probably looks a bit like this, where treatment 1 is given, and then it fails as PSA rises again. Then treatment 2 is given, and then it fails. Then treatment 3 is given, and then it fails, and treatment 4 is given, and it fails, et cetera, et cetera. More sobering is the fact that individual patients will often respond very differently to the various therapies being given to them. On top of this, different healthcare providers will pick various treatments based on their own preferences for therapy. Adding to the intense anxiety is the fact that many of these forms of therapy probably do bring patients close to a curative outcome. Unfortunately, these opportunities for cure, which are sensed by the patient, often seem to pass by unrecognized by healthcare providers who might be more focused on a palliative outcome to therapy. Finally, even when a patient receives the very best form of therapy provided by the very best of healthcare specialists, treatments can still fail in very unexpected ways. I think I've quoted this before. This scenario reminds me of a line from a famous poem by Robert Burns. The best laid schemes, O mice of men, oft go awry. So the goal of my presentation today will be to discuss how I think a patient might be able to use PET imaging to better navigate their cancer treatments with the hopes of achieving more complete responses to therapy or even a curative response to therapy. So what can I say about PET imaging? Well, first, of all recent innovations related to prostate cancer, I feel that the introduction of PET imaging has been the most impactful for improving prostate cancer management. PET imaging can instantly and precisely tell a patient where trouble is brewing within their own body. By knowing exactly where cancer is growing and spreading within the body at any given moment in time, I believe that a patient, together with his healthcare team, can wage a more effective war against the patient's cancer. Using the metaphor of war, what I'm trying to say is that you need to see the whole battlefield to win the war. In medical terms, PET imaging can instantly tell you the precise distribution of cancer within an individual's body, and by doing so, PET imaging can also tell you the appropriate treatment or treatments that can be used to fight a patient's cancer. In addition, PET imaging can immediately tell a patient whether he is responding to therapy or if a patient is failing therapy so that he can pivot to another form of treatment in a timely fashion. Finally, certain forms of PET imaging might also tell a patient whether his cancer might be treatable using other forms of therapy, such as focal radiation therapy or radioligand therapy. So, what is PET? PET is an abbreviation that stands for positron emission tomography. So, how does PET imaging work? First, a tiny volume of specifically designed tracer molecules, typically labeled with a radioactive isotope such as fluorine-18, gallium-68, or carbon-11, is drawn up into a syringe. The tracer molecules are then injected into the blood using a vein in the patient's arm. These tracer molecules then spread throughout the patient's body until they encounter prostate cancer cells, depicted in blue here. The tracer molecules then stick to the surface of cancer cells like Velcro or cockleburrs, or are sucked up by the cancer cells depending on which type of tracer is being used to image the patient. At this point, the tracer molecules start to degrade. And as the tracer isotopes degrade, they give off energy, zing. The energy is then captured by a three-dimensional array of detectors around the body, which feeds information into a computer. Simultaneously, the same imaging machine that is used to perform the PET scan is also used to perform a crude CAT scan or CT of the patient's body. In the end, a series of CT images and a series of corresponding PET images of the patient's body are captured. On the left is a CT image taken through the middle of a patient's chest. On the right is a PET image for the same location within the same patient's chest. As you can see, the PET image is depicting some bright spots in the patient's chest, whereas the CT scan doesn't seem to highlight anything abnormal. Subsequently, through the miracle of modern science, colors are assigned to reflect the intensity or brightness of radio tracer taken up by the lesion seen in the PET images. And then the CT and the PET images are merged together to generate what is called a PET-CT fusion image like this one. As you can see, the areas that previously revealed abnormal tracer uptake now show up as a bright green lymph node and a faint blue hazy spot in the lung. These sites are suspected to represent sites of cancer within the chest of this individual. So the question remains, what makes PET imaging so special over and above the conventional forms of imaging that we already have? Conventional imaging typically refers to three forms of imaging that have been around for a very long time, like me, including bone scan, CT scan, and MRI. Although useful in specific situations, conventional forms of imaging are associated with significant limitations for assessment of advanced prostate cancer. Foremost amongst these limitations is the fact that conventional imaging typically only sees big problems, usually when PSA is greater than 20 to 30 nanogram per ml. Adding insult to injury, in contrast to PET imaging, which can see the entire body, in one study, you need multiple different forms of conventional imaging to survey the entire body of a patient. For instance, when PET imaging is not available or feasible, we often order either a bone scan plus a CT of the chest, abdomen, and pelvis to assess our patients, or alternatively, a bone scan plus chest CT and abdominal and pelvic MRI to fully assess our patients. And finally, conventional forms of imaging are extremely slow to depict changes in response to therapy. In addition, conventional imaging cannot easily differentiate between live versus dead tumors and cancer cells. For instance, here are PSA levels for a patient who is treated with radiation therapy for a resistant tumor affecting his right pubic bone, depicted by the red arrows. As you can see, his PSA gradually dropped from 13.3 nanogram per ml to an undetectable value over approximately 10 months following radiation therapy. Using CT scanning alone, you can see how difficult it is to assess what's going on with this patient's pubic bone lesion following his radiation therapy. Likewise, it's hard to see what's going on with this patient's cancer based on MRI imaging of his pubic bone, even 10 months after radiation therapy has been administered. In contrast, PET imaging clearly shows that this patient's pubic bone tumor is dying out in response to his therapy in a fashion that is commensurate with this patient's decline in PSA from 13.3 to an undetectable value over 10 months. In summary, I find that conventional imaging is a bit insensitive, inefficient, and sluggish for the assessment of prostate cancer, especially in the context of therapy. I believe that conventional imaging, when used alone, can lead to erroneous or delayed understanding of the clinical situation, including assessments of response to therapy. In contrast, PET imaging provides an immediate, extremely sensitive, accurate, and efficient way to assess prostate cancer within the body. We've already reported that PET imaging can see prostate cancer 7 years in advance of what conventional methods of imaging provide. As a result, PET imaging provides a huge advantage when it comes to finding and treating prostate cancer. In addition, within the last decade, PET imaging has essentially revolutionized much of what we know about prostate cancer biology and treatment responses. So let me pause for a second to express this opinion. I've been taking care of advanced prostate cancer for a very long time now. And the one lesson that I have learned for certain is that nothing is for certain with regards to prostate cancer. It doesn't matter how many glowing papers have been published about a new great drug or therapy. It doesn't matter what your Gleason score is or what the newest biomarker says about your cancer. It doesn't matter where you fall on the statistical predictive nomogram. The bottom line is that the unpredictability of this cancer is an absolute certainty on any given day. As such, you absolutely need to keep a keen eye on what your cancer is doing throughout your journey with this cancer. At any rate, going back to the topic of PET imaging, there are now multiple forms of prostate cancer PET imaging available. This includes metabolic forms of PET, such as FDG, C11 choline, and Axumin PET imaging, as well as gallium-68 and F18 forms of PSMA marker-specific PET imaging. Related to this, when a patient gets an Axumin, C11 choline, PSMA, or FDG PET scan, This means that they were injected with a radio tracer corresponding to these types of scans. It doesn't mean that a special type of machine was used to scan the patient. In general, all PET scan machines can image any of these radio tracer agents, okay? For the sake of today's lectures, I'm going to talk mostly about the marker-specific form of prostate cancer PET imaging called PSMA PET. So how does PSMA PET imaging work? Well, the radio tracer that is injected into the body in order to conduct a PSMA PET study actually sticks to a protein called PSMA, which decorates the outer surface or membrane of prostate cancer cells. PSMA stands for prostate-specific membrane antigen, and you don't want to confuse PSMA with PSA. PSA is prostate-specific antigen. This is prostate-specific membrane antigen. They are not related, those two proteins. At present, there are 3 PSMA targeting radio tracers that have been approved by the FDA for evaluation of advanced prostate cancer, including Locomets, Pylarify, and Posluma. These radio tracers differ in terms of the design of the linker molecule that binds to PSMA. In addition, these tracers can differ in terms of the radioisotope that has been incorporated into the radio tracer molecule itself. Even though there are subtle differences in the performance of these PSMA marker-specific PET radio tracers, I think they all perform equally well in the clinical setting. Admittedly, the multiplicity of PSMA imaging tracers is confusing. Luckily, however, there are only about 60 more PSMA radio tracers currently under development for the future. So that was just my attempt at a little sarcastic humor. Anyway, for the rest of my presentation, I'll be talking about PSMA PET as a generic term for all the various forms of PSMA PET imaging that are currently available. So when should a patient with prostate cancer get a PSMA PET scan? It is recommended that PSMA PET imaging should be used to rule out metastatic cancer spread in high-risk patients who are being considered for initial treatment with radiation therapy or prostatectomy. It is also recommended that PSMA PET imaging should be used to identify sites of local or metastatic cancer relapse or progression in patients who are or who have failed primary forms of treatment. Finally, the FDA and NCCN recommends that PSMA PET imaging should be used to select patients with metastatic disease who might benefit from radioligand forms of therapy, such as 177 PSMA lutetium, also known as Pluvicto. Related to this, for reasons that completely mystify me, many providers still only use PSMA PET as a 1 or 2 time form of evaluation for their patients. Consistent with guidelines, we use PSMA PET imaging to evaluate patients with metastatic prostate cancer, but we do not use PSMA PET as a one and done tool for evaluation of our patients. Instead, we use PSMA PET before, during, and after therapy to confirm that a given treatment has elicited the type of response that we are anticipating for our patients. Therefore, in our clinic, patients with advanced prostate cancer who are receiving therapy typically undergo PSMA PET imaging at regular intervals to assess for residual or even progressive refractory sites of cancer that might not be responding to therapy as expected. Bottom line, starting therapy is only 1/4 of the battle. Follow-up and interim adjunctive therapy are key to optimizing your therapeutic outcome. In the immortal words of Ludwig van der Rohe, the devil is in the details. I really butchered the guy's name, but you get the point. One more thing, major warning here. Do not initiate any form of therapy, especially hormone therapy, before you undergo an initial PET scan. If you start therapy before you undergo the PET scan, you will end up with a completely faulty assessment of your cancer situation. So the next question, should a patient know how to read his own PET scan? At Mayo, our patients are able to review their PET images prior to their clinic visits. In addition, my entire team has been trained to read and review PET images with our patients during each of their clinic visits. All of our rooms have double viewing screens, one for the provider and one for the patient. By doing this, I believe that our patients feel more able to understand their clinical situation. In fact, I've been extremely impressed with how well our patients are able to interpret, process, relate their PET studies to their clinical care. I believe that our patients feel more empowered and more welcomed to participate in assessments of their treatment, as well as any future planning of their therapies and follow-up. Finally, since PET evaluation for prostate cancer is a relatively new technology, sometimes not all healthcare providers are entirely familiar with interpretation of PET imaging results. Also, radiology reports are sometimes vague, incomplete, or occasionally inaccurate. As such, I feel that you should never assume that your healthcare provider totally knows what your PET scan might be revealing about you and your cancer. Therefore, as often as possible, you should ask your provider to review your PET images and PET scan reports with you. Always ask questions about your scans. In summary, I do feel that knowing as much as possible about how to interpret PET images and PET reports will greatly enhance your ability to make informed decisions regarding your own cancer care. Therefore, I do think that patients should know as much as they can about how to review their own PET scans and PET reports. So what does a PSMA PET scan actually look like? Well, there are multiple views provided by a PSMA PET scan. At Mayo, for fusion views, there are transaxial, coronal, and sagittal views of PSMA PET available. There is also the non-clinical grade CT view available. As the name implies, the non-clinical CT is not as high quality as clinical grade CT, but it does provide a useful backbone for the fusion PET CT images that I just showed you. There's also the advanced reconstruction view of only the PET scan. This view is not computer colorized and it is not superimposed on top of a corresponding CT image. This view does offer some advantages for viewing, as I will show you later on during this presentation. Finally, there is the maximal intensity projection view, or MIP view, which is my favorite PET image view. This view shows the distribution of radiotracer within a 3D reconstruction of the entire patient and often enhances the identification of cancer within the body. So when a patient sees his PET scan for the first time, one of the most common questions that I get is the question, is all of that stuff that lights up cancer? The answer is no. Many normal organs pick up radiotracer in a PET scan. For instance, on a PSMA PET scan, the salivary glands are intense because the cells that make up the salivary glands, or spit glands, have very high levels of PSMA protein within them. Also, the liver and the intestines light up because they also pick up the PSMA radiotracer. Likewise, the kidneys, the ureters, and the bladder light up because PSMA radiotracer is eliminated by the urinary system. Finally, the spleen also takes up PSMA radiotracer because it doesn't want to be known as the forgotten organ. Just joking. I have no idea why the spleen lights up. By the way, the transaxial view is like looking at a cross-section of a person's body as if you were examining slices of bread in a bread loaf. By convention, you should always imagine that the person is laying on his back and that the person's legs and feet are extending towards you. Thus, by convention, this means that this side is always the right side and this side is always the left side of the person. Finally, sites of potential cancer involvement are typically identified based on the appearance of radiotracer in areas that typically don't take up radiotracer, like this metastasis on this sacrum of this patient. Also, the size of the cancer spot on a PET scan is typically much larger than the actual tumor itself, since the PET image represents a bloom of energy. Just think of looking at a beam of light coming out of a little flashlight at night. The beam looks much bigger than the actual flashlight itself, okay? To facilitate the identification of potential sites of cancer spread, suspicious sites are often highlighted with color. At Mayo, we use a colorimetric rainbow system to denote low-intensity lesions that appear kind of bluish, moderately intense lesions that appear green to yellow, or very intense lesions that appear orange to red, like this metastasis on the sacrum. In general, the more intense the lesion, the higher the probability that the spot represents a site of prostate cancer involvement. In addition, suspicious lesions are also assigned a maximum standardized uptake value, also known as SUV max. It is useful to think of an SUV max number like a lumen value or lumen rating that is used to rate the brightness of a light bulb. In general, SUV max values of 2.5 to 3 are suggestive of cancer, and the higher the SUV max value, the more likely the lesion represents a site of cancer metastasis or spread. So now I think you should be ready to learn about how prostate cancer can spread through the body and how you can interpret your PSMA PET reports and assess your PSMA scans for sites of cancer involvement. So to begin with, we're going to start with the head and neck region of the body. Throughout this portion of the presentation, I'll be showing you a variety of different PSMA PET views to illustrate how sites of disseminated prostate cancer can appear during PSMA PET imaging. This is a cross-sectional view of a patient's head. In all of these images, the red ball marks the front of the patient. This area represents the brain, which is typically bland and lacks activity on a PSMA PET scan. This is the brain. Under normal circumstances, PSMA radiotracer only shows up in 3 locations in the head, including the tear glands. Here's a tear gland, and here's a tear gland near the eyeballs. This proves that men can cry. In addition, sometimes you see PSMA radiotracer in the nasal cavity of a patient. And then finally, the main place that you see PSMA radiotracer is in the salivary glands or the spit glands, which are located on either side of the face, under the cheeks, as well as underneath the jaw. Those are the salivary glands. Those happen to be the same places that get infected with mumps. So that's why you swell up there when your salivary glands gets mumps. But those are the normal places where you'll see PSMA radiotracer in the head. In the patient with cancer, however, PSMA-avid prostate cancer metastases can be seen in any of the bones of the skull. So this patient clearly has a metastasis that's involving the skull cap of his skull, okay? Prostate cancer can also invade into the inner bones of the skull. This patient presented with hearing problems in his right ear, and that's because cancer was actually invading into his inner ear on the right-hand side in the skull here, okay? Prostate cancer can also commonly spread to the jaw and sometimes masquerades as a dental problem. So this individual actually had a prostate cancer metastasis to his jaw right there. At first, we thought this was a dental problem, but it turned out to be a metastasis. Likewise, prostate cancer can spread to the brain itself inside of the skull. So here's an individual who has prostate cancer, which has clearly invaded into his brain. Okay, that's a brain metastasis. With regards to the neck, prostate cancer often spreads to the neck bones, also known as the cervical spine vertebrae. So there is metastasis involving cervical spine. And prostate cancer also commonly spreads to lymph nodes at the base of the neck, as is seen in this patient. So this patient had prostate cancer in the lymph nodes in his neck, down to the base of his neck. And you'll see all of these little lymph nodes filled with prostate cancer, right? So what about the chest? There are basically three areas in the chest that you will see in radiology reports. This includes the lungs, the mediastinum that contains the heart and big blood vessels, including aorta and vena cava. And finally, there are the two roots of the lungs that often harbor lymph nodes called pulmonary hilar lymph nodes. In general, the chest is normally relatively bland and boring, okay? This is a normal chest, and I'll take you through it. The central part of this is the mediastinum. This is where the heart and the big blood vessels are. This is the right lung. This is the left lung. All of these structures are ribs. This is sternum or breastbone. This over here is the shoulder blades. And of course, this is the thoracic spine, or the spine of the thorax, okay? On occasion, you will see a little bit of color associated with the esophagus, as well as pulmonary lymph nodes, and that's just background noise on a PSMA PET scan, all right? Since the chest is usually so bland and boring, I typically like using this view to inspect the chest of my patients. This view is called the advanced reconstruction view, which only shows PSMA radiotracer as it flows through the organs and tissues that comprise the human chest. This particular view is extremely sensitive and very useful to find subtle, small metastases that can appear within the lungs in up to 10 to 20% of patients with prostate cancer, all right? In contrast to a normal patient, this patient has fairly obvious prostate cancer metastases around his windpipe, as well as heart and lungs. So you will see it immediately on this advanced reconstruction view. All of those little white spots are areas of prostate cancer metastasis to the mediastinum and to the lungs, etc. Okay? This is a maximal intensity projection, or MIP view, for a patient whose right lung is being replaced by prostate cancer. So clearly you can see the right lung here is completely being taken over by prostate cancer. This patient has extensive prostate cancer metastases involving all of the bones that constitute his chest, all right? So this includes the shoulder blades, the ribs, the thoracic spine. Here's a shoulder blade spot. Also, all of these ribs, even the breastbone here. those are all metastases invading into the bones that basically are the perimeter of the chest, okay? So what about PSMA PET imaging of the abdomen? What can we say about that? Unlike the chest, the abdomen is filled with organs that pick up the PSMA radiotracer. This includes the liver, spleen, kidneys, and intestine. So on this view, this is liver. Here's left kidney, right kidney, intestines. And there's that tricky spleen right there, all right? The abdomen is pretty tricky to evaluate, but there are some tricks that you can use to inspect the abdomen. Specifically, you should focus on this little area inside of the white triangle. This area is located in the back of the abdomen and in front of the spine. This space inside of the triangle is part of what is called the retroperitoneum or retroperitoneal space. By the way, best album ever. The reason you want to inspect this area within the triangle is because the main blood vessels of the body, the aorta and the vena cava, course through this region of the abdomen. All right? Aorta, vena cava. And they both go through the little triangle there. More importantly, lymph nodes that drain and filter fluids from the pelvis follow these major blood vessels out of the pelvis, through the abdomen, and then through the chest until they join the main blood circulatory system in the left neck at a location called the thoracic duct. Each of these lymph nodes acts like a little oil filter, which can catch cancer cells that can grow into sites of prostate cancer metastases. So just think of the human lymphatic system like a chain of oil filters that strains fluids that are flowing from the feet to the neck of a person. So here's an example of a patient who has many prostate cancer lymph node metastases in his retroperitoneal space next to his aorta and vena cava, all right? So as we go down here, you will see there's one right there. There's a bunch more here. These are all lymph node metastases that are hanging around the aorta and vena cava. We also went by a big lumbar spine metastasis there, all right? And this is a MIP view of the very same patient. See all of the lymph nodes there in the retroperitoneum and in the pelvis? Can't miss them, right? Occasionally, we do see liver metastases during PSMA PET imaging as well. So this patient has a liver metastasis, one big one right there. See it? It's in the liver, this big red area. In this patient, however, PSMA PET imaging revealed multiple liver metastases visible in the MIP images. You can see those clearly. Our group was the first to report that prostate cancer can relapse inside of a surgical port site in patients who have undergone robotic prostatectomy. Here's an example of an abdominal wall port site recurrence that we found using PSMA PET imaging in a patient with a serum PSA of 1.7 nanogram per ml. That's where the port was put through to do the robotic surgery. This is a patient who has multiple liver metastases as well as metastatic prostate cancer surrounding all of his intestines in the abdomen, as is shown on this MIP view. So this individual has a tremendous amount of prostate cancer metastases invading around his intestines, into his liver, etc. Very tragic, all right? So how about the pelvis? The pelvis is surrounded by a ring of bones. The sacrum and the tailbone are in the very back. Kind of hard to see on this illustration. The iliac bones are the largest bones and are located where you feel your belt wrap around your waist, okay? The ischial bones are the bones that you feel when you sit on a hard seat. The pubic bones are just above the base of the penis. Finally, the hips come into the pelvis on both sides, and this is the femur associated with the hip, all right? In the back of the pelvis, the aorta and vena cava split into left and right iliac blood vessels that serve the left and right legs and pelvic organs. Many of the lymph nodes inside of the pelvis follow alongside these iliac vessels. In front of the iliac vessel sits the sigmoid colon and the rectum. In front of the rectum sits the bladder and the ureters. In a patient who has had his prostate removed, the prostate or seminal vesicle bed or fossa resides in between the back of the bladder and the front of the rectum. Just like the abdomen, many of the organs within the pelvis accumulate PSMA radiotracer, making it sometimes difficult to see small deposits of prostate cancer within the pelvis. Organs that take up PSMA include the ureters, as well as the bladder, colon, and rectum. So sometimes these things are mistaken for lymph nodes, but they are the ureters. Those are the sites that carry, or the structures that carry urine down to the bladder. This is intestine that's picking up some of the PSMA tracer. This is the bladder, which picks up or removes PSMA tracer from the body. And then this is the rectum behind the bladder, which also picks up some PSMA. Like the abdomen, lymph nodes represent common destination for prostate cancer metastases. As in the abdomen, lymph nodes follow the major blood vessels that run through the pelvis. The blood vessels are known as left and right iliac vessels. Okay, so here you can see the lymph nodes following the aorta and vena cava as it splits into the left and right iliac vessels. And you can see all these lymph nodes have low metastases in them, all right? Prostate cancer metastases also frequently target the multiple large bones that constitute the pelvis, as is seen in this patient. So as you go down, you can see all of these metastases occupying the major bones of the pelvis. Pretty clear, right? Occasionally, prostate cancer can metastasize to the penis, as this PET image reveals in this patient with a PSA of 3.4. So this patient has a tiny metastasis to the tip of his penis. You can see it on PSMA PET imaging. Even worse, PET imaging will sometimes reveal prostate cancer directly invading into the penis. This patient actually presented with unremitting erection caused by cancer invasion into his penis. PSA of only 0.19, all right? Finally, using PET imaging, we do find prostate cancer metastases in testicles of some of our patients, as was the case with this individual with a PSA of 1.8. He has a testicular metastasis here. And this is the ultrasound that shows the metastasis inside of the testicle, okay? For those of you who like lists, here's a partial list that I've prepared for you that shows various locations of prostate cancer recurrence and metastasis that might be encountered during PET imaging. Even though PSMA PET imaging seems like it would be very specific and accurate, it is still prone to false positives, which means that PSMA PET scans sometimes light up other things in the body that are not related to prostate cancer. For instance, old scars in areas of inflammation or infection will sometimes light up on a PSMA PET scan. Anomalies of the salivary glands or spleen can also look like sites of prostate cancer on a PSMA PET scan. Benign tumors or malformations of the bone or organs, such as hemangiomas, can also be seen on PSMA PET scans. Likewise, other malignancies, such as kidney cancer, bladder cancer, colon cancer, and other cancers may light up on PSMA PET scans. Finally, ribs frequently exhibit false positive spots on PSMA PET imaging in up to 10 to 20% of patients. Most of these false positive lesions represent old scars or benign tumors of the rib. You really can't do much of anything to reliably confirm or refute false positive findings in a bone such as rib. So this is one of those false positives. There's a spot there. A couple more spots here and there, probably old wear and tear. Biopsy of a bone lesion is typically associated with about a 50% rate of false negatives. Even worse, it is often impossible to locate the proper spot on a bone to biopsy, since lesions found using PET are generally invisible on conventional imaging. So it's hard to know where to stick the needle when you see something that might be a false positive or false negative. Okay? So as much as possible, you need to avoid the trap of using conventional imaging and biopsies to confirm suspicious lesions seen on PET imaging. So for instance, sometimes I'll see a spot on a PET scan, I send the patient for treatment, my colleague thinks it's a false positive lesion, they request an MRI and a biopsy, the MRI can't see the spot because it's conventional imaging, the biopsy comes back negative because they didn't biopsy the right spot, treatment ends up not being given, months pass, patient comes back, spot gets bigger, and then we go back into the circle of confusion. We want to try to avoid this as much as possible. Likewise, sometimes healthcare providers will dismiss a suspicious PET lesion by suggesting that the lesion lacks radiographic correlate, such as sclerosis within a bone. Sclerosis is scarring of the bone marrow caused by late stage or previously treated cancer. You don't want to wait for radiographic correlates to appear before taking a PET lesion seriously, all right? When we encounter a suspicious lesion on PET, we tend to treat the lesion, especially if the lesion fits or makes sense within the context of the clinical scenario. Alternatively, when in doubt, we will wait 3 months and repeat the PET imaging to assess the growth and activity of the lesion before we treat it. Sometimes we'll also give a short bout of androgen deprivation therapy to see if the lesion regresses in order to more firmly establish whether the lesion is a prostate cancer metastasis. So what are the limitations of PSMA PET imaging? Well, one limitation of PSMA PET imaging is that PSMA PET imaging cannot easily see relatively small metastases in the brain or the liver. For these two organs, magnetic resonance imaging, or MRI, is usually required to rule out small metastases. For instance, this young man with prostate cancer was complaining about seeing flashing lights. As you can see, his PSMA PET didn't show anything alarming around his eyes or in his brain, all right? Nothing abnormal. Unfortunately, this patient's MRI of the brain revealed a very different story. So on MR imaging of his brain, you can clearly see all of these little white spots appearing, and those white spots are tiny little metastases that have landed inside this patient's brain, causing his symptoms. Likewise, here's a patient who presented with some abnormalities in his liver function tests, specifically AST, ALT, alkaline phosphatase. PSMA imaging of his liver appeared relatively normal. On MR imaging of this patient's abdomen, however, one can readily see replacement of the liver by highly infiltrative metastatic prostate cancer. Devastating finding. PSMA PET imaging also has difficulty seeing things around the bladder. Since PSMA radiotracer needs to circulate within the patient for about an hour prior to imaging, the bladder often fills up with PSMA radiotracer. As a result, the glowing bladder often precludes seeing small sites of cancer in and around the bladder. Okay? Just think of staring at the sun and trying to see Bogart lighting a cigarette next to the sun. It can't be done. In contrast, C11 choline PET imaging is performed immediately following radiotracer administration. As a result, the bladder doesn't glow. This is something that's important for you to know, since approximately 50% of all patients with prostate cancer recurrence will have some degree of relapse seen around the bladder, either within the prostate, seminal vesicle bed, or around the rectum, or inside the bladder itself. As an example, you can see that this PSMA PET scan looks fairly normal for this patient who has a PSA of 2.5 nanogram per ml after his prostate was surgically removed, or as Mark Scholes likes to say, snatched. In contrast, C11 choline PET imaging clearly reveals a likely site of prostate cancer recurrence within the wall of this patient's bladder. Right there. There's the spot. Recurrence of prostate cancer in this patient was further confirmed using MR imaging of the prostate and pelvis as seen here. In general, it is almost always necessary to image the pelvis and the prostate region with MRI in order to find small areas of cancer recurrence in the pelvis around the bladder, especially when you're using PSMA PET imaging. For the same reason, it's sometimes hard to see cancer invasion into the rectum. In this PSMA PET study, a wisp of PSMA radiotracer is seen extending off the back of the bladder on the right. So just watch for it. And there's the wisp of PSMA radiotracer, okay? Once again, MRI was used to confirm the presence of rectal invasion by prostate cancer in this individual. So another common question that we encounter in my clinic is the question, how come my doctor can't find my cancer using PSMA PET imaging? In general, the reason for this is that PSMA PET imaging, as well as all other forms of imaging, cannot see very tiny deposits of prostate cancer in the body sometimes. Related to this, patients often feel that PSMA PET should rapidly find their cancers, especially since PSMA PET imaging was advertised for use when PSA is 0.2 nanogram per ml or higher. Based on my experience, however, for most patients, finding sites of prostate cancer relapse at a PSA value of 0.2 nanogram per ml is relatively unlikely. In our experience, the sweet spot for starting to identify sites of prostate cancer recurrence using PSMA PET imaging is a PSA of about 1.0 to 2.0 nanogram per ml. For most patients, PSMA PET imaging will likely be negative at values lower than 0.5 to 1.0 nanogram per ml. Nevertheless, we still encourage patients to get PET imaging early on, since the objective of PET imaging is to identify sites of cancer recurrence as early as possible. As you know, we firmly believe that early treatment greatly facilitates more durable or even curative outcomes of therapy. By the way, once in a while, we do encounter situations where sites of prostate cancer are accidentally excluded during PET imaging. In this patient with a PSA of 3.8, the top of his head was cut off during initial PSMA PET imaging. As we learned later on during repeat PET imaging, this turned out to be the location for prostate cancer recurrence in this individual. Related to this, it is not routine to image patients below their knees, since prostate cancer rarely metastasizes to sites in the lower leg exclusively. However, on rare occasions, this does happen, so watch out. How about the situation in which PSA goes way high, but repeat PSMA PET imaging cannot identify sites of prostate cancer relapse? How does something like that even happen? This scenario occurs for two reasons. For 10 to 20% of patients with advanced prostate cancer, their tumors might not produce PSMA protein, and therefore their tumors might not be visible during PSMA PET imaging. We'll talk more about this situation later on. For most other patients with multiple negative PSMA PET scans and a high rising PSA, the reason PSMA PET imaging might not be able to identify sites of prostate cancer relapse is simply because the sites of cancer relapse are tiny, multiple, and far spread out. For instance, it is much easier to see something like this compared to something like this. Get the picture? So where does the cancer eventually show up in the patient with this type of problem? Rising PSA, can't find it on a scan. Well, we recently studied this question. For most patients with high rising PSA and multiple PSMA PET scans that were initially negative, prostate cancer relapse was most often identified in the retroperitoneal lymph nodes, in that little triangle, or in the lungs. For instance, here's a patient who had multiple negative PSMA PET scans previously. When this patient's PSA finally achieved a value of 53 nanogram per ml, we were able to finally identify multiple small PSMA-avid metastases in the retroperitoneal space and in the upper pelvic lymph nodes of this individual. So you'll see it right. See those little spots there? Those are the lymph nodes filled with prostate cancer. Hard to see. Likewise, here is a patient who had multiple negative PSMA PET scans previously. When this patient's PSA finally reached the value of 23.2 nanogram per ml, we were able to identify multiple small PSMA-avid metastases in the lung of this individual. So as we move down here, you can see a very faint lung metastasis there. One here, little ones over here. Spread out, small, hard to find. So what about the 10 to 20% of patients who have forms of prostate cancer that do not express PSMA marker at all? As I mentioned previously, PSMA PET is not the only type of PET imaging that is available to assess advanced prostate cancer. In addition to PSMA PET imaging, there are also multiple forms of metabolic imaging that are available, including FDG PET, C11 choline PET, and Axumin PET imaging. At Mayo, we typically employ C11 choline PET to image patients who we suspect might have relapsing forms of prostate cancer that do not express the PSMA marker. Outside of Mayo, however, you can probably also use an Axumin PET scan or FDG PET scan to look for prostate cancer metastases that can't be found using PSMA PET imaging. So who do we feel is at risk for developing or harboring a form of prostate cancer that does not express PSMA? As I mentioned before, if a patient has a rising serum PSA plus multiple prior PSMA PET scans which failed to reveal their cancer, we seriously entertain the possibility that this patient might have a form of prostate cancer which doesn't express PSMA. Generally speaking, patients in this category often have a history of poorly differentiated Gleason 9 or 10 cancers, for cancers with ductal intraductal features, for cancers with neuroendocrine or small cell components. These nastier forms of cancer can sometimes fail to express PSMA de novo. Also, any patients who have symptoms or laboratory abnormalities and multiple negative PSMA PET scans, even if their serum PSA value is 0, should be evaluated for non-PSMA expressing prostate cancer using one of the metabolic forms of PET imaging. Finally, patients who have previously failed systemic therapy, such as hormone therapy, chemotherapy, and especially PSMA targeting radioligand therapy, such as 177 PSMA lutetium or Pluvicto, are at high risk for having cancers that cannot be imaged by PSMA PET imaging. For instance, here's a patient who presented with a rising PSA after prostatectomy for Gleason 9 prostate cancer. Multiple PSMA PET scans, like this one, failed to show any abnormalities whatsoever, clean as a whistle. In contrast, C11 choline PET evaluation of this same individual obtained during the same week revealed multiple sites of choline radiotracer uptake within the retroperitoneal lymph nodes. So here's the choline PET scan, and it shows you a bunch of fat little lymph nodes in the retroperitoneal area. And that's where the prostate cancer is hiding on this individual who had negative PSMA PET scans. Along a similar vein, this is a young individual who's complaining of severe left pelvic pain while on hormone therapy plus enzalutamide. PSMA PET scan showed nothing abnormal. In contrast, choline PET imaging of this patient clearly revealed a linear mass in the left side of his pelvis. So this patient, this is the cause of his pain, this linear mass right here. The same linear mass was also seen on pelvic MRI, right here. Okay. The mass was biopsied and confirmed a recurrence of poorly differentiated adenocarcinoma of the prostate within the pelvis. Here's a different example. This is an individual who has previously been treated with triple therapy, chemotherapy, ARPI, androgen deprivation therapy for metastatic prostate cancer. The patient then developed recurrent disease with a PSA of 87.2 nanogram per ml. This patient was then treated with 6 cycles of 177 PSMA lutetium Pluvicto, and his PSA dropped to 6.3 nanograms per ml. At this point, the patient's PSMA PET scan looked pretty good. As you could see, only little minor areas of residual prostate cancer were seen on the scan. Unfortunately, this patient continued to complain of worsening weight loss, fatigue, and generalized pain. The patient also had a rising alkaline phosphatase. Prompted by this, we obtained a choline PET scan for this individual. Choline PET scan revealed extensive, poorly differentiated metastatic prostate cancer. Tragic. As I have previously explained, one of the main strengths of PET imaging is its ability to stratify prostate cancer into various categories of disease, such as local, focal, zonal, or diffuse forms of prostate cancer. By stratifying prostate cancer into an appropriate category, the patient and his healthcare team can select the most appropriate form of therapy to treat his cancer. Once again, I encourage you to scan this QR code to review some of our previous presentations where we have discussed the role of PET imaging for proper stratification of disease prior to treatment. Anyway, in this part of the presentation, I'll be discussing the role of PSMA PET imaging for management of focal forms of metastatic prostate cancer, commonly referred to as oligometastatic prostate cancer or oligometastatic disease. Oligometastatic forms of prostate cancer were first described by Dr. Weichelbaum and Dr. Hellman at the University of Chicago in 1995. Oligometastatic disease classically refers to 5 or less sites of metastatic cancer spread. Anyway, Weichelbaum and Hellman felt that oligometastatic disease encompassed, and I quote, a state of limited metastatic cancer between localized and widely metastatic disease where radical local treatment might offer a curative potential. So they were thinking just like we are now. But this original description of oligometastatic disease far predated the use of PET imaging for treatment of cancer. As such, I feel that PET imaging is now facilitating the identification of the most nascent forms of recurrent metastatic prostate cancer that have ever been visualized by any of us in the medical field. Anyway, my clinic handles about 8,000 patient visits per year, and my clinic has employed PET as a primary modality for imaging since about 2007. As such, we have performed nearly 40,000 PET evaluations for our patients thus far. Within this experience, we have performed roughly 10,000 PSMA PET studies since PSMA PET was first approved by the FDA in 2020. For our population of patients, we estimate that roughly 20% of our patients will exhibit an oligometastatic form of prostate cancer at some point during the course of their care with us. Of these patients, about 75% will exhibit 1 to 2 metastases. Based on my experience, I feel that these patients are excellent candidates for metastasis-directed treatment with possibility for cure. In contrast, in my opinion, the vast majority of patients with 3 to 5 oligometastatic lesions who are treated with metastasis-directed therapy will only receive palliative benefits from treatment unless the metastasis-directed therapy is coupled with some adjunctive form of systemic cytotoxic therapy, such as radioligand therapy or chemohormonal therapy. Very important to know. For those of you who do not know, metastasis-directed therapy, or MDT, refers to the process of destroying metastases that fall within the definition of oligometastatic disease, meaning 5 or less small metastases. In essence, MDT refers to a medical game of whack-a-mole. Anyway, our group was one of the original proponents of metastasis-directed therapy. Since about 2007, we've been involved with several thousand metastasis-directed therapeutic procedures. This is a partial list of metastasis-directed therapies that we employ in our institution. Related to this, I would like to draw your attention to the fact that there are multiple non-radiation-based forms of metastasis-directed therapies that can be used to treat oligometastatic prostate cancer. Please note that some of these forms of therapy can be used in combination with radiation therapy to effect more complete responses to overall treatment. Without question, treating 1 to 2 metastatic lesions can be highly gratifying and highly beneficial for patients. When we treat 1 to 2 lesions with MDT, we virtually never add a systemic form of therapy, since that completely clouds the question as to whether we are treating an isolated form of early cancer spread or a first wave of widespread metastatic disease. So we don't use systemic therapy in that setting. Here is an early example of how we used stereotactic irradiation to treat a solitary hormone-resistant lumbar metastasis in this individual back in 2012. There's the lumbar metastasis. That's what we treated with stereotactic irradiation. And now I'm happy to report 12 years, 7 months later, this patient still remains disease-free. This patient is now 92 years old And in my opinion, he is the OG of MDT, all right? Likewise, here's an example of how we used surgery as a form of metastasis-directed therapy to eliminate a hormone refractory solitary metastatic lymph node from the pelvis of this individual. This patient has since remained disease-free for the last 9 years and 8 months, even after halting his hormone therapy, all right? Finally, here's an example of how minimally invasive chest surgery was used to remove a hormone-resistant lung metastasis from this patient with a PSA of 1.1. The surgery was performed by Dr. Steve Casfy, who has now completed nearly 300 of these procedures at Mayo over the last 10 years. This patient has remained disease-free for 3 years now, and the patient is off hormone therapy. In summary, I think that metastasis-directed therapy can be highly beneficial and even curative for well-selected patients with 1 to 2 discrete small metastases identified by PET imaging. In addition, metastasis-directed therapy can be repeated for a patient who returns with 1 to 2 discrete lesions many months or years after their first procedure. But I must caution you, metastasis-directed therapy must not be used in lieu of common sense and aggressive systemic therapy, especially when it's clear that a patient most likely harbors widespread disease. Overuse of MDT can be very detrimental in this setting. Now let's talk a bit about metastasis-directed therapy as an adjunct to systemic therapy. When patients undergo systemic therapy in our clinic, we repeat PET imaging every 3 cycles of chemotherapy or after every 2 cycles of radioligand therapy. The purpose of this is to rule out cancer persistence or progression while a patient is on active therapy. The rationale for repeating PET evaluations of our patients while they are receiving systemic therapy is simple. Metastatic disease is very heterogeneous, and we often see that systemic therapies leave behind small pockets of treatment-resistant cancer. Fortunately, these oligometastatic sites of resistant disease can be readily identified and destroyed thanks to PET imaging. We strongly believe that aggressive early treatment of evolving metastases during systemic therapy greatly facilitates a more complete and durable overall response to treatment. For instance, here's an individual who initially presented with large retroperitoneal and pelvic lymph nodes and a PSA of 28.1. The patient was treated with 6 cycles of taxane-based chemotherapy, docetaxel, cabazitaxel, whatever, with an excellent response to treatment. During treatment, however, the patient's PSA failed to decline below 0.2 nanogram per ml, and a new metastatic lesion evolved in the patient's L5 vertebral body right there. This lesion was treated with stereotactic irradiation, and now the patient is free of disease. Excellent outcome to overall therapy, all right? Likewise, here's a patient who had 2 resistant metastases seen on PSMA PET imaging after receiving chemotherapy. There's number 1 and there's number 2. These 2 lesions were subsequently treated with stereotactic irradiation with excellent results. This image looks a little bit like an early Picasso, right? Relevant to this discussion, I'm proud to say that my group has one of the largest experiences with treating patients with radioligand therapy in all of North America. Since its approval by the FDA in March of 2022, roughly 3,000 patients have been treated with 177 PSMA lutetium at Mayo. Of these patients, roughly 85 to 90% have been treated through my clinic. For those of you who do not know, Pluvicto is a radioligand therapy that works by specifically targeting the protein PSMA to deliver a beta-emitting radioisotope called 177 lutetium. Once this radioactive particle binds to PSMA on the surface of prostate cancer cell, it's swallowed by the cell, and then the radioisotope delivers radiation to the cell and other cancer cells around it, causing these cells to die. In our clinic, all patients who receive 177 PSMA lutetium therapy undergo repeat PSMA PET imaging after every 2 cycles of treatment. We also repeat choline PET imaging in some of these patients after they complete therapy. What we have learned is that some of these patients will evolve an oligometastatic disease profile during or after treatment with 177 PSMA lutetium. For instance, here's a patient who presented with a PSA of 6.1 and treatment-resistant metastatic prostate cancer. This patient was given 6 cycles of treatment with 177 PSMA lutetium with a near complete response to therapy, both in terms of his serum PSA and radiographic findings. On first follow-up, 3 months after completing Pluvicto treatment, the patient's PSA rebounded to 1.8 nanogram per ml. PSMA PET scan revealed a new T8 vertebral metastasis. This T8 metastasis was treated with stereotactic radiation, and the patient's PSA dropped nicely to an undetectable value, and now the patient is free of disease. As I alluded to before, we do find oligometastases in patients who have been treated or are being treated with 177 PSMA lutetium. As such, I think that PET imaging combined with metastasis-directed therapy represents an important adjunct for treating patients who receive radioligand therapies such as Pluvicto. So what are some of the surprises and weird things that we have discovered about PSMA PET imaging? Since PSMA PET imaging was only approved for widespread use about 3.5 years ago, we're still digesting what PSMA PET imaging is telling us about the biology of prostate cancer. To quote Sir Elton John and Bernie Taupin, "And all this science I don't understand. It's just my job 5 days a week," right? As you probably already know, we previously reported that roughly 12% of patients with a history of prostate cancer and an undetectable serum PSA value will have metastatic disease that can be seen on C11 choline PET imaging. We previously labeled this type of patient as a PSA 0 type patient. To be honest, I thought that C11 choline PET imaging would be distinct in its ability to identify metastatic disease in patients with undetectable PSA values. But I was wrong. In the study that we will soon publish, we found that 12% of patients who had undetectable PSAs and who were evaluated using PSMA PET imaging also exhibited metastatic disease. In support of this, here are 3 different patients with undetectable serum PSA values who exhibited metastatic disease on their PSMA PET images, okay? These days, I feel that these kinds of patients are all over the place in my clinic. Perhaps most worrisome is the fact that it appears that the 12% of patients identified using PSMA PET imaging do not necessarily overlap with the 12% of PSA 0 patients identified using C11 choline PET imaging. At this point, I suspect that these PSA 0 findings do likely portend something a bit ominous for patients with prostate cancer. Anyway, here is a patient that has an undetectable PSA and metastases predominantly seen on C11 choline PET scan, but not PSMA PET imaging. And here is the opposite situation for a patient that has undetectable PSA metastases predominantly seen on PSMA PET scan, but not C11 choline PET scan. stranger than fiction. Related to this, we've also observed that PSMA PET might be surprisingly slow to reflect changes induced by therapy when compared to metabolic scans such as C11 choline PET. For instance, here's a patient that we evaluated with C11 choline PET scan imaging in 2012. At that time, the patient had external metastasis. We found it and we gave it a radiation. 3 months later, the spot is gone. PSA dropped to 0. Quick response, quick changes, quick decline in PSA. Here's a similar patient who was imaged with PSMA PET and who underwent stereotactic irradiation of a sternal or rib lesion. As you can see, this patient's PSA dropped to an undetectable level relatively quickly, but his PSMA avid metastases persisted for about 10 months after radiation therapy was given. Okay. Likewise, here's a patient who immediately achieved an undetectable PSA value after starting hormone therapy. However, his PSMA PET scans failed to exhibit significant changes over the next 19 months following initiation of therapy. Shifting gears, we previously reported that 10 to 20% of men receiving systemic therapies for advanced prostate cancer will exhibit cancer progression on C11 choline PET scan. Despite favorable decline in serum PSA values, we referred to this phenomenon as a paradoxical response to systemic therapy. As with C11 choline PET imaging, it appears that PSMA PET imaging also reveals paradoxical responses to therapy, as is seen in this individual who experienced a favorable decline in PSA during treatment with taxotere and carboplatinum, but exhibited alarming disease progression on PSMA PET imaging. In summary, PSMA PET imaging encompasses a game-changing technology which has dramatically enhanced our ability to treat prostate cancer more effectively. Nevertheless, given the relative newness of PET imaging, in general, we still have much to learn about what PET imaging is telling us about the biology of prostate cancer in the clinical setting. So as always, I have to thank the people I work with. I literally work with the top people in the field in every bracket. So we have an outstanding PET group, Doctors Lowe, Johnson, Packard, Kendi, Jacobson. They're all the elite of PET imaging. We have a minimal invasive group. They're really innovators and pioneers. They can basically destroy or ablate virtually anything using the tip of a needle. We have some of the best MRI people, Dr. Adam Froming, Dr. Petretsky here at Mayo. We have outstanding salvage surgeons, Dr. Carnes, Dr. Tolfson, Dr. Frank, Dr. Khanna. Our radiation oncology group is really elite. We have Dr. Park, Dr. Davis, Dr. Stish, Dr. Phillips, Dr. Wilson, Dr. Waddell, Oliver, Traubauer. They're the best of the best when it comes to radiation. Our thoracic surgeon, Dr. Caspi, he's an innovator and an outstanding surgeon. And now we have Dr. Keith here to oversee our medical oncology group, Dr. Childs, Dr. Orm, Dr. Quevedo, Dr. Pagliaro, and the person I started my clinic with, Dr. Hujek, all top medical oncologists. And then finally, I have the best team in the world. Nobody can run a clinic like we run it because of these people. This includes Becky, my administrator, or administrative assistant, Lindsay, who does all of our scheduling for 8,000 patient visits a year, Jamie and Danielle, they're my nurses, Carrie, Amy, Madison, and Christine, they're the best physician assistants or nurse practitioners that you could ever find. They know prostate cancer probably better than most faculty at most other institutions. They're crackerjack. I encourage you to scan this QR code to review some of our previous lectures. They might help you understand what I was talking about today. And if you want to schedule an appointment with our group at any time, call this number and you can schedule an appointment. That's it.
Dr. Kwon, you are awesome. That was good stuff, man. That was awesome stuff. I mean, it was about an hour and a half plus, but it was top notch. I know how hard you've been working on this for the past 6 months, but I want to show you how much effort I put in to making your talk. So today we got hit by a major storm, no kidding, but I did everything I could to walk the dog, go for a run, and make sure I would catch your talk in time. So this is a photo taken just a few hours ago down the street. Look at that. Isn't that unbelievable? That was honestly taken about 4 hours ago. And you can see how we just got hit with this major snowstorm coming over Lake Michigan. I think it came over from Minnesota. You sent it to us. So look at my dog Grazie and myself. I was freezing. And this is me heading back to the house in anticipation of making your lecture. How do you feel about that?
Well, I feel honored that you would make such a large effort to walk the dog before my talk.
Look how excited the dog was to hear you talk too. You know, dogs have a prostate too. People forget that.
I've spoken to your dog before. Your dog hears my voice and gets excited.
I know, actually, that's true. That's when you come to visit me, your dog will be very excited to see you. All right, I just wanted to show you how great, how amazing the PCRI team is and how everybody, regardless of the wind and the weather, we always make the lecture happen. All right, I thought I would ask you one more question because I've known you so long, so I can ask you questions like this. I want to ask you one quiz question. Are you ready for a Moyad quiz? What takes more time? A, to listen to Dr. Kwon's entire PSMA lecture, or B, to read the entire book, War and Peace, over 1,200 pages? Which one do you think?
I think it probably takes more effort to listen to my talk, to be honest with you. At least that's how I felt when I made it, you know. I actually, the original slide set had an FDA black box warning that said that if you listen to Dr. Kwon lecture too long, you will lapse into a coma. And so, you know, but I decided I'd take it out. So
In all deference to Dr. Kwon's patience and his entourage, he has a huge entourage. I'm the guy that when he calls me at 6 in the morning in December and says, I'm thinking about doing a talk on PSMA, I'm also encouraging him to take as much time as possible. So obviously, you know, this is tongue in cheek. I do think it's probably faster to read War and Peace, but for the audience, for the behind the scenes, we actually encourage him because people are using these as primers, as a foundation on learning PSMA. And we never really had a master class given on PSMA. So I consider that a master class. Now, I also told you that I think this DIY combat manual, whatever you called it, is a great name. I still believe, and we put this title, What I Have Learned from Over 10,000 PSMA PET Scans, Dr. Quonology, I think is the more appropriate title. And is that really true? Can you elaborate? Have you really ordered or gone through? Oh, that's got to be number one in the world. Over 10,000 PSMA scans because PSMA scans haven't been around that long.
I sent you the data. I had to actually ask for the data from our group. And basically, yeah, I think we're over 10,000 PSMA PET scans. We have 8,000 patient visits a year, and we do a fair amount of follow-up on our patients. So it's not that much. And that's only half of the PET imaging we do because we also do choline almost equally as much.
Okay, so over 10,000 scans. Never asked you this before. I only have 30 minutes with you. So I've got to ask you a bunch of potentially related and unrelated questions. What's the biggest surprise that you've learned after 10,000 scans? That's question number one. The biggest thing that you thought, I know it's going to go this way because you know we're all in this boat, right? You think it's going to go this way, and clearly now the data shows with the scan it goes that way. So the biggest surprise, and then what was something that you expected from the very beginning of FDA approval that still holds true today? Can you kind of walk me through that? What's the biggest shocker to you as far as PSMA scans? And then what was something you expected early on that's stood the test of time besides our relationship?
I had really mixed feelings about the PSMA PET scan when it was rolled out because we were doing C11 choline PET imaging, and I thought that C11 choline PET had certain advantages that PSMA PET would not. This is kind of getting down into the weeds, but since this is a master class, so as you know, PSA is a marker of prostate cancer, and PSA is not necessarily all that reliable for telling you what's going on with prostate cancer under certain settings. So I kind of expected that we might run into the kind of same situation with PSMA PET imaging, where certain patients where their PSAs went downwards, you didn't really see that much on a PSMA PET scan, and you'd see a lot more on a choline scan because it's agnostic to markers. It's a metabolic scan. But I think the thing that surprised me most of all is nothing I predicted, absolutely nothing I predicted played out the way I thought it was going to play out.
Hmm.
PSMA PET scan is clearly a much easier and prettier scan to read. But PSMA PET scan is sometimes bright and patients are filled with spots even when PSA is 0. The other weird part of it that I put into my talk is the fact that a lot of times you treat the guy or you treat a patient and the PSMA PET scan doesn't change. And I went back to Novartis, I went back to the manufacturers, and I said, hey, why doesn't this thing change when we treat these patients? And their response was, we don't know what you're talking about, Kwon. You're the only guy that's getting follow-up on your patients. So it was a little bit surprising, and it's so much so that some of our radiation guys here don't even like getting follow-up PSMA PET scans because the scan doesn't necessarily change. So they'll order a C11 choline PET scan because that shows very rapid responses, and what you see coincides with what you expect based on PSA and based on the treatment that you gave. I'm not sure that just getting another scan, though, really is the solution to this very perplexing question. To me, if the spots are still there after you're treating, my greatest worry is that those spots represent hibernating or dormant disease that you haven't killed off with your therapy. All right?
Okay.
So, and that's a problem because as we know, many patients, even if you treat them very aggressively, they will still have ways of having disease relapse down the road. In one way, I think it's kind of an ominous finding that sometimes these patients don't clear their scans on PSMA. On the other hand, though, I think it's a huge opportunity because I personally feel that those spots that remain after aggressive therapy are exactly the forms of disease that we need to go after in order to evoke a cure or force a cure. That's where we a lot of times take the foot off the gas pedal when we see PSA goes down and we've treated the patient. But if you still see spots, I think you have to take them seriously, and I think you need to treat them. So the bottom line is, and I tried to point that out at the end of my talk, there's a lot of things that we're still sorting out. And there are a lot of surprises that I just did not anticipate. I never anticipated that people within our institution would be swinging back to choline PET scan because they thought it's better for reading responsive therapy. I never expected to see patients who had PSAs that go to 0, who still have spots on their PSMA PET scan. You know, I'm still sorting through all of this.
Because another cancer is, if you use another type of PET CT and you see the SUV you talked about or the brightness, if you see it decrease, there's an assumption that the treatment's working, right?
Correct.
So I just think off the top of my head, like FDG PET and lymphoma or something
Yeah.
like that. Okay.
Yeah.
So are you saying that, and I just want to ask you this one more general question before I go to some other questions. So are you saying you feel comfortable now as far as the choline PET scan is concerned that when you see a reduction in brightness or you see a reduction in a spot, that essentially that means there's tumor killing going on, that you're eradicating tumor after that?
Well, so that's the other half of the confusion.
Yes.
So what I see on a PSMA PET scan has also made me rethink a little bit what I see on choline PET scan. So choline PET scan is metabolic.
Right.
So you see the metabolic activity where the tumor goes to sleep. So there's two possibilities for that. Either you killed it or it went to sleep. On the PSMA PET scan, sometimes you see it disappear, sometimes you see the tumors are still there. So when I put everything together, I think that these two forms of scan, these two forms of imaging are probably helping us understand when we've completely treated the patient versus when we've injured the tumor and it's gone to sleep but not gone away. Does
Yeah.
that make sense?
Yeah.
And
Yeah.
that, I think, is an opportunity to be more aggressive, possibly to ward off any kind of relapse in the future.
It makes sense, but it freaks me out a little bit. And I'll tell you why it freaks me out a little bit, because I want to backtrack because this has become such a hot item. And we actually have somebody internally looking at this and is going to handle some of this in the future, which we'll talk about. So this is a general question. I'm not expecting you to provide the ultimate answer, but this has become the question because PSMA has become standard, right? Standard of, I don't want to say standard of care, standard of imaging. Maybe that's the word. So let's say this. Insurance says no. Now, where do you go? What can you do? You know, because I asked you a question a couple of years ago. I said, when an insurance company says no or denies the scan, then there's nothing you can do. And you said, I was just asking you the question. It was rhetorical and somewhat. And you said, no, there's always something you can do. So before we go on and talking about, you've talked about the importance of PSMA. So almost everybody watching this is going to ask themselves the question, should I get a PSMA? Should I get another PSMA? Should I get another type of PET CT scan? But before you put the cart before the horse, is that the cart before the horse or before the dog? I don't even know that anymore. What do you, what's your experience with insurance? And I know for a fact that people are also being denied out there. And then what's your experience? And then if there's a denial, what do you recommend?
What I've learned, and it turns out that this answer is also a little bit more complex than I first anticipated. So for patients that come to Mayo, I think that, our business office and coding and all of that is a little bit better at getting PET approvals than other practice networks. So I think that it depends partly on your practice network, what you belong in. So some places you can't get PET.
Yeah.
Patients say they just won't get PET. I mean, patients that come to us, I think the vast majority of our patients get PETs, and we don't seem to have a problem with that. When we do have a problem, however, so if a person says to us, my insurance provider will not permit me to get a PET scan, I basically respond by saying document, document, document. You have to document the reasons that they're denying you a PET scan. And then you have to write an appeal that is intelligent and coherent. And that's one of the motivations for giving this lecture so that people know what the language is, what they should be putting into their appeal letters. So the first step is appealing the denial. The second part is appealing the denial. The third part is appealing the denial. The more you appeal, the more likely they will overturn the denial. I think that it's pretty well understood that, this is a little bit of a business model that insurance companies handle. But it's very important to document the reasons why they're denying it so that you can appeal in a logical fashion to say, well, you said it was a coding error. or you said that it had something to do with it's not indicated. And then you have to respond accordingly. I really think that, for most of our patients, what we tell them is you just have to constantly appeal and you have to constantly go back over and over and over again and try to convince your insurance provider to provide the scan. And I think that you have to use words that, you find in a lecture like this or in other reviews to make the argument that it's important. NCCN guidelines, even for this presentation, I went on to see what is NCCN guidelines saying now. I mean, they're basically saying that, PET should be considered equal, if not better, to conventional imaging. So there should be no discussion at all. The only reason that the discussion comes up is because people permit the insurance providers to say no, and they have to volleyball that back to them,
So who's documenting and who's doing all this work? Is it the physician? Is it the patient? Is it both?
The patients, the patients that we have that fight for their scans, like I said, they're a very motivated group. They know how to read their scans. They know how to understand it. You cannot get appeals with your insurance provider if you're expecting your doctor to do it and you don't know the language. You have to do it yourself. And that's why, I make these combat manuals, because I think more and more and more, I think patients are going to have to kind of, advocate for themselves to get coverage and evaluations that they very much need.
Yeah, so they're going to have to work with their doctor to appeal, and doesn't the appeal have to happen with some alacrity, right? I mean, it would make me wacky to be rejected and then think about, wait, I gotta not only put all this together, I gotta submit it in a timely fashion so it then can be approved the second time, right? Because doesn't it take a little while in your experience, even when you submit a rebuttal?
I feel very kind of strong about this. I think that there's a lot of things that happen in this world that are not in the best interest of people. And I think that it has consequences at times. I think that any delay in terms of evaluation and treatment of a patient with cancer is nothing short of the worst form of torture that you can inflict upon another human being. Unfortunately, I don't have a remedy for it, The only remedy I really have is you have to learn the language, you have to learn how to write the appeals, and you just have to be very, very, very kind of vigorous about your appeals. But I do think that there are differences based on where people are getting their hospital care. I've been actually quite surprised that, patients over here may not be able to get pets, but then they go over here and they can get pets. So I think that, it's not something that I totally understand. And also, you have to understand, even when a patient appeals, sometimes one person will appeal over here and they'll get someone totally different the second time around. So, there's real variability in the whole process. You just have to be persistent.
But if two types of scans are needed, let's say, doesn't matter, let's say a choline and a PSMA, how much harder is that to get two? I mean, that sounds like, to me, it sounds not, I don't want to use the word impossible. That seems very daunting.
It depends on who the insurance provider is. It depends on, kind of how we basically place it in the evaluation. We'll say, this patient has negative PSMA PET scan and needs a choline. We have lots of patients that the following week they're able to get the second PET scan. But, there are patients that they say, well, we'll only do 3 a year, or we'll only do 1 a year. Those ones kind of drive you crazy, but you just have to stay on them.
Well, I mean, you've gone through a lot of successful appeals, so I just, that was part of the reason of calling your talk what I've learned from over 10,000 scans, because for what the audience has to remember is that you may have done 10,000 scans, but there is no way in HE double toothpicks the insurance company said 10,000 for 10,000. Oh, no problem. Just go do it. So I think you were as good as anybody just to comment on what you have to do to eventually get it approved. All right. Which makes me think of something else. Again, I'm going to stay general here.
Okay.
I haven't seen anybody ask this really of people who are doing a lot of scans. And I don't know what you say to the persons outside of Mayo. We talk about it on MRIs, but you ever talk about second opinions on a scan? I mean, do you ever see? We had Jeffrey, right? I call him Jeffrey. It's like maybe I'll call him Dr. Johnson. Uh, but I don't know. I'm friends with him now. So, we talked about, I didn't talk about this. I should have asked him this question. Now we talk about second opinion. Some people will read an MRI that's a little bit ambiguous and get somebody else in another institution to read it. Second opinions on pathology. Think about that. Think about when you and I, in the beginning, the early days, when we were much younger lads, second opinion on pathology was like, what? And now it's almost standard. Now there's second opinion places all around the country. So what's the situation with second opinions on a PET CT scan or a PSMA or any type of scan like that? If it's a little bit ambiguous, do you guys run into that? Do you guys and gals run into that?
Whenever a patient comes from outside our institution, if they've just undergone a PET scan, we actually will mandate that it be reviewed here before we engage with discussions with the patients. So every one of the scans that comes in from outside gets our readers looking at it. And I try to, again, the reason I'm giving the talk, as painful as the talk was, the reason I'm giving the talk is because there's a lot of variability in quality of PET imaging and interpretation of PET imaging and what the reports say and what they don't say and errors in the PET imaging. This is a new technology that's only been out there over the last 3 years.
That's right.
And the vast majority of people that are ordering PET scans, I personally feel, know very little about PET scans. Okay? Their readers may be better, but even the readers out there are not the best. There's a lot of variability in levels of technology. There's good scanners, bad scanners. There's good readers, bad readers. Even within Mayo here, my team reads the scans while we go over it with the patient because, it's new. And sometimes the information is not as accurate as you think. So that's why I thought it was very important to give this talk.
Yeah.
Because I think patients should know this is a relatively new technology and they should know something about it because they may actually end up knowing more than their healthcare provider on the subject. So when we get PET scans, we always have them reread. And it's amazing how many of them are a little bit odd.
Well,
Yeah.
no, I don't want to spark controversy, but when you say, so you always read the scan if it was done outside the institution, which more and more places are doing that, and people should make sure they're doing that, right? So when you say some of them are odd, I'm interpreting that to mean is that some of them you disagree with. And the question becomes in the top of my mind, now, I'm not trying to be controversial. Again, this is about doing 10,000 scans, the most I've ever heard. So you have that experience. Out of the 10,000, are we talking about 1%, 5%? You change your opinion? 18? I mean, can you even put a number on that?
For the stuff that comes from outside, I mean, it's, probably on the order of 5%. You're going to find some major differences. And some of them are what you would expect, oh, that's not really a lesion. That's a piece of valve,
Yeah.
So, but it's enough. I think where it really gets tricky is, it's kind of like we see a lot of patients that it says false positive on the rib. It's like, are you kidding me? That's not a false positive on the rib. The thing lights up like the sun, and the PSA is 1.1. What else can it be? That's got to be real, okay? Or you see something that they say, well, that's probably inflammation. And you're sitting there and you're saying, that's not inflammation. That's a big fat lymph node there.
Yeah.
So this is where I think the egregious type of totally off readings, probably about 5%. The gray area region or the gray area readings where we see something that we think is more important or less important than what someone else sees, that's probably about 20%, you know? So experience counts, I think.
That's why I always found it funny that people always talk about experience when it comes to pathology. Why aren't they talking about it in terms of reading images? These are just humans, unless, which is an important question, because I know what's happening in pathology. Is there, do you see some of your group and others in radiology starting to potentially work with AI to provide a better potential read, or are we just not there yet?
You know, reading with AI may have applicability, just like reading with pathology.
Yeah,
It's all going to depend on how the software is set up and the data sets that go in to program the machines that are going to do this. If garbage goes in, garbage is going to come out, you know.
yeah,
I do think that if AI supported reads of PET scans might be useful, with the caveat being that everyone's going to have to use standardized technology and everyone's going to have to standardize what machines they use and what detectors they have and so forth and so on. If you don't have that standardization, I think it's going to be all over the place. You know, you're going to
yeah.
get variable readings. So I think AI is going to have some value in certain places, but even so, you know, I think that there's still value to reading it on your own. Um, you know, when I look at these scans, I mean, I constantly am trying to fit the scan together with what the clinical story is.
Right.
That's very nuanced, I think.
It's very nuanced. I just found it stunning. I was listening to a lecture from some top pathologists a couple weeks ago, and the number of them felt that I wouldn't say take their job, but would have a prominent role in reading pathology slides within the next 5 years or so. And I thought, wow, that's pathologists admitting that. That's that accelerated. That was pretty shocking. So anyway, let's spend the rest of our time talking about the positives and negatives of the different scans that patients might run into. And of course, we're going to end up with PSMA alphabetically. How does that sound? Because all these scans are thrown out there. Of course, this was a talk about PSMA, but this is also a review of scans you might run into with your practitioner. And I just want you to know a little bit of good and bad about each one of them so they have the objective story. How does that sound? So let's go through my alphabetical list. At the top of my alphabetical list, and let me give this introduction, is choline, which was actually the first PET CT scan for prostate cancer ever invented. Is that correct?
Yeah, it was the first ever approved by FDA. Right.
Absolutely. So the
Correctly.
FDA, this is from the FDA. I pulled it for you because I'm such a nerd. You think you're a nerd. I will compete with you anytime on nerdom. All right, this is the original from the FDA. Choline was approved back in 2012, so it was the first. And you know what? And then you read through it, and then at the end, the FDA and the prescription information essentially says, well, here's the references that we used to FDA approve it. And then it says, I circled it. They used Kwon E twice. That sounds like you, unless you have a brother that's also a Kwon E. So they used some of your research and your colleagues' research, and this got approved in 2012. Am I correct so far?
Yep.
You should be proud of that. That's an incredible historic moment. So now you have the first approval. So let's go through some positives and negatives. And I don't care which ones, how we fit these in. I put Mayo. Can I get choline anywhere else but Mayo? Is there only Mayo? You know, is it only Mayo, whether it's in Arizona, is it only Mayo in Rochester, or can I get choline in other places?
The choline PET scan was actually brought to Mayo by Dr. Val Lowe, who's one of the nuclear medicine people, and he had it all set up here. It got a bad rap because Europe had used choline PET scan to evaluate prostate cancer, and they said choline PET scan was bad. So Europe had already concluded that it was useless. Our experience was different because the dosing for choline that we use is actually anywhere between 2 to 4 times greater than what they used in Europe. So our imaging was much better when we set up to go for FDA approval. So the dosing made the difference for us. And the dosing is what permitted us to break the ice with the FDA to get the first approval for PET for evaluation of any cancer in the world. That was the first one. That was the only number 6 PET imaging agent ever approved. So having said that, we had the option of protecting our trade or leaving it wide open. And we left it wide open. And the reason we did that was we thought that other people might want to practice choline PET at their institutions, but it never happened. And the reason it never happened was, number one, because everyone thought it's lousy because of the European experience. And number two, in order to do it, you have to have these little devices called cyclotrons in your basement. And it actually is kind of entertaining. So we are able to have a cyclotron that is right below our PET scanners because we live out in the middle of nowhere. But you cannot have a cyclotron that's right below your PET scanner when you live in a place like New York City or Boston or Michigan, University of Michigan. A lot of times, you know, because of all of the urban sprawl, your cyclotron may be 10 miles away from your PET scanners. You can't have that arrangement with C11 choline PET scan because C11 only has a half-life of 17 minutes. So the minute it's produced in the basement, you have to shoot it up in the tube and shoot it right into the patients. It's choreographed, and it's choreographed down to the second. So we ended up being the only people that really practice C11 choline PET in the United States. Technically, it can be done other places.
Yeah.
I think that people would find it cumbersome and difficult to institute because of, you know, what's going on in their city or whatever. And now they have PSMA PET.
Is it done at any other Mayo sites, do we know?
We had it going for a while, I think, in Florida, and I think we had it in Arizona. I don't know if it's still going at those locations.
Yeah, because PSMA, but that's interesting. But here's the other thing I thought was interesting, the prescribing information, and then we'll move on. Because this is a PSMA PET lecture for the most part. After I show you this, I'm gonna ask you the positive thing about the choline PET CT that the audience should know about, and one of the negatives, okay? Besides the fact that it's not widely available. I love this stuff because this is me, not you. This is in the prescribing information. And I knew this, I just think it's a reminder that lifestyle makes a difference. Fasting for at least 6 hours is recommended to minimize the potential for dietary choline interference with radioactivity uptake in tissue. That's the patient preparation. Is that still true? That just like in FTG, you ask people that they have to fast before choline? Because dietary choline is found, it's ubiquitous in the diet. Let's face it, it is. And so if someone reads that in the instructions, do you still follow that, or is that now nonsense?
I think it's probably nonsense. I really have not seen anyone who comes in and says, oh, I had a big Denny's Grand Slam breakfast, and I guess that's why my PET scan's negative. We've done some of those things with some of our patients out of fun, you know. We've said, oh, you know, don't eat your eggs or eat your eggs. I don't think it makes any difference.
Okay, so you don't think it makes, so that was initially in 2012, you launched that because of the initial concern, but that doesn't necessarily bore out that what you do.
No, I think that we probably incorporated that into the language based on theoretical stuff, you know.
Okay. Tell me, just when we move to PSMA for the rest of the time, tell me who needs a choline PET CT in 2025. Is that where we are? And what's one concern you still have about it? This is a really tough question to answer, but that's life.
Yeah, I mean, I think that I think that, you know, like I said, people are treating patients and they're not getting some of the answers they want. And some of that I think is due to the fact that the cancer does lose as it becomes less differentiated. It loses PSMA expression. So we're seeing more and more patients that had dedifferentiated cancers that show up brightly on the C11 choline PET scan,
Does
but
okay.
do not show up necessarily very well on PSMA PET scans.
That's including early stage disease as well as later stage disease?
Usually, kind of, I think that where you're really running into that is patients that have been treated systemically with one or two agents.
Yeah.
We see it a lot in patients that have had ARPIs and they've suppressed the disease and then it recurs. And the recurrent disease is typically poorly differentiated. We
Yeah.
see it in patients that get Pluvicto because you're targeting, you're picking off the PSMA guys, and you're leaving behind the non-PSMA expressing cancer cells that
Yeah.
then grow out and take over. So I think that, you know, that have for patients that haven't received some form of systemic therapy, I think that the worth of the C11 choline PET scan is increasing relative for those patients compared to PSMA PET.
So choline naive. And we
What?
say, I said choline naive. They're if they haven't had it, they're not finding much on PSMA.
No, no, no. If they're treatment naive, I think PSMA PET scan is good.
Okay.
They are very treatment experienced, I think choline PET scans become more and more important.
So if they're treatment experienced, even though if they've had plenty of different types of treatment and they've moved on to other forms of treatment, but they've never had a choline, that's a good candidate.
Probably.
Okay. I like that. But overall, would you say the negative is that now we have PSMA and PSMA overall, I'm generalizing, is superior to choline, or is that not fair?
That all presumes that, you know, you have one treatment and you're going to cure it once you get the scan, right? But
Yeah.
I just don't think that's the reality for most patients. I think that the storyline that I try to deliver is if at first you don't succeed, try again. PSMA PET scan, without question, is a great first try for the vast majority of patients. No question about it. But just because you got one PSMA PET scan or two PSMA PET scans and you've thrown one or two therapies at it, you can't make the assumption that you're out of the woods. And that's where people like us get very aggressive. We're like, okay, you know, the point of this is to beat the disease completely, not just do good in the first inning of
Yeah.
the game, right?
Yeah.
So that's where I think that it's an asset to have more than one form of PET scanning up your sleeve. Because if you're going to be persistent and aggressive about treating a patient, you're going to have to think about repeating PSMA PET scans, and you're going to have to keep it up your sleeve that you might also have to resort to other PET scans to take inventory of what's going on with the patient's disease so you can knock it out completely. Does that make sense?
Does make sense. Which brings me to leaving Mayo Clinic. Now, the two types that are still out there, I don't hear as much about it, fluciclovine, this other type here, which do you see much of that? Do you guys and gals see much fluciclovine PET CT going on, or has it just dropped off tremendously since PSMA, like everything else?
Yeah, I think that PSMA PET imaging has dominated the scene. I haven't seen a lot of Axumin PET imaging. Probably 1% of our patients come in with Axumin scans.
But at least, if something's not showing up and people are looking for another option that can be expressed after multiple treatments, it'd be interesting who would be best to qualify.
Well, I think you have to remember that the other thing that's going on here, PSMA PET imaging was just rolled out 3 years ago, so the wave is high.
Yeah.
But I think that people are going to re-equilibrate and say, well, this is when we need to get metabolic scanning. You can already see it in the literature. People that are doing radioligand therapy, they're like, well, we need to follow up with an FDG PET. It boggles my mind because I said in the beginning, if you're targeting PSMA, you might need a different form of PET imaging afterwards because you picked off all the PSMA positive cancer cells, right?
Yeah.
So I think that part of what we're seeing right now is just PSMA PET imaging is the new kid on the block.
It's the new kid on the block, and there are a lot of different companies now offering it. So I don't know if you want to comment on that. I think my take home, it was about a year or two ago, as everybody started wanting to offer their type of PSMA scan. You actually put it well. I don't know if you remember, you said that it's better just to get a scan than to fight over the nuances and particulars of which one is better in this situation because not enough people are simply getting them. Do you still feel that way with all these new companies coming in?
Yeah, there's no question. I mean, I believe it or not, we're still fighting the battle and we still hear it all the time. Oh, well, he needs a CT scan or he needs a bone scan. And to me, it's just mind-boggling that we're even still using those modalities as primary tools for assessment of our patients. The bottom line is when it comes to PET versus no PET, PET wins every time. It doesn't matter what PET you get. You got to get PET.
Yeah.
Anything is better than conventional imaging for evaluating prostate cancer.
Well, because can you just tie that into a bow nicely? It is sort of shocking that a lot of people are doing conventional imaging, but the PET-CT does everything all the old imaging does in one time. At one time, you get the combination of 3 different scans in basically one scan, if not more, right? Tell me what PET-CT is bad at. You can see the organs, correct? You can see the bones. You can see the lymph nodes.
So there's no
And you can see
question,
the prostate.
right?
And so tell me why someone needs all these other scans, like a bone scan or a regular conventional CT, when a PET CT tends to do all of that in one shot.
If you're looking for, well, number one, if the question is, if I had all the scans in front of me, which one would I pick first? I would always pick PET. No question about that. So a PET scan is excellent as a first step. Where it is weak is that if you suspect tiny things in the brain, in the liver, or around the bladder, you have to get MR imaging. Okay, no question. So you can't totally.
I want you to repeat that because MR is still as popular as ever. We were talking about bone scans and we were talking about a straight CT, but again, can you repeat those situations where the PET CT needs a partner?
If you suspect small metastases in the brain, in the liver, or around the bladder, you have to get an MRI dedicated for those areas because those happen to be areas where the PET either won't light it up or there's too much background uptake that blots out your ability to see small things. So I would say that, start with PET, and then if there's suspicion there's something around the bladder, get a pelvic MRI. If there's suspicion that something's going on with the liver, and you have to have a very high index of suspicion, okay?
Yeah.
Poorly differentiated disease, something's going on, liver enzymes are wacky, whatever. Get an MRI. We get MRIs on our patients at least once a year because you can never predict who's going to have small liver metastases versus who is not.
Yeah, it's amazing how many times MRI sort of breaks the confusion and takes ambiguity and makes it clear.
Yeah.
So when you mentioned the brain, the liver, PSMA has huge uptake, just normal uptake in the liver, so it's not really good at picking up liver mets overall, right? And then we'll talk about excretion in a minute in terms of where PSMA is. I just wanted to leave this other one. Let me mention one other thing about PET CT. I hear about the exposure to radiation. Now, is this too much radiation to be exposed to? Now, here's my counter, and tell me if this is a bad counter. Why doesn't somebody add up all these separate images? So PET CT does everything that all these other images do. But nobody ever adds up that if I got a bone scan and a CT scan and you add up all that radiation, is that still going to be a lot less than PET CT PSMA? So
For
how
the
do you,
sake of, yeah,
I think so. How
yeah,
do you,
for the sake of this presentation, I was trying to actually get all the exact numbers. So I
yeah,
had a group of people that were doing the calculations and trying to figure out what the total dose of radiation is for a CT and a bone scan and an FDG, C11 and all this stuff. And after about 2 weeks, I think they all quit. So, what I understand and what's been explained to me by Dr. Val Lowe when we were first going for C11 choline PET imaging was that the total dose of irradiation given on at least C11 choline PET imaging is roughly about a quarter of the total dose of what you get with a CT scan of the body. Okay.
thank you. Yes.
So in my mind, if that's true, 4 PET scans equals 1 CAT scan. So then if you have a patient and you say, well, you need 3 CAT scans in a year, they're getting a whopping dose of radiation. And then if you couple that with a bone scan, which is all radiation, I
Yeah.
mean, I don't see how, the two compare. It's not even comparable. So I think the argument in terms of radiation exposure is PET is much better than conventional imaging. The one area that's not true is MRI doesn't give you radiation. MRI is, just twisting around hydrogen molecules inside a magnet. So
Yeah.
that's not radiation.
Yeah, no, that's well put because I think in general, the medical field, I'm not saying you, has been a bad advertiser of radiation exposure when it comes to PET CTs versus the conventional ones that the PET CT replaces, which is what you're saying. Because a lot of times what you hear from folks in the work in the radiation world is, oh, don't sweat it. It's just like you get radiation in an airplane going from LA to New York twice or three times. I'm going, that's not working for me. I need something more pithy to put my hands around. And what you said, whereas really when you put it in context, the PET CT overall radiation exposure compared to getting all these other things done multiple times, all those other things add up to a lot more. It's kind of scary, actually. I'm not trying to minimize the radiation exposure. I'm just saying I'm trying to put it in perspective. Are we good with that? And we're just going to move right into the rest of the talk. I'm already over. You always do this to me. You get me involved in these conversations, and then sometimes I get memorized. I sort of look mesmerized. That's the word I'm looking for by the Pink Floyd picture in the back, and then I can't concentrate. I think you do that on purpose, Kwon. I thought it was really interesting that you used the word sweet spot. Here's a handout I like to show a lot of the time. This is from one of the trials with PSMA PET. And so you're trying to look, whether it's recurrence, whether it's early stage disease. It shows what you said, that like with choline and like with other PET CTs, the chance of finding something gets greater in terms of probability with the higher the PSA. So although you see the advertisement of, hey, you've had surgery, for example, and we can pick up something at 0.2, in reality, they found in one of the strongest trials that it was only about a third that you could pick up something, that you had to wait till PSA got between 0.5 and 1 just to go to 50%. And then you go 1 to less than 2 was 66%, and then it went higher. Now, the criticism of my little handout here is that since 2021 in this trial, people have become a lot better at reading scans, and these numbers have gotten better. But it goes back to your sweet spot, which just scared me. You said the sweet spot for PET CT to pick up cancer is between 1 and 2. And let me show you what I did. I fell out of my chair. And I'll tell you why I fell out of my chair, and I want you to answer this. I'm going to play devil's advocate here. Here's where the patients complain about the sweet spot. You're asking me to wait till my PSA gets to 1.0. The problem with that is the radiation oncologist, who's a friend of mine or my brother or a friend, says you can't wait till a PSA of 1. In order to cure this thing, the lower the PSA, the better the chance of curing with radiation, especially after primary treatment. But yet Kwon still says the sweet spot is between 1 and 2. What say you, Dr. Kwon?
Well, if they're your brother, you should stop communicating with them if they're your neighbor, you should probably move away. So, you know,
But you understand the dilemma here.
this
That
is
you,
an age, this is the basic genesis of my clinic. So, you know, the bottom line is we know that the radiation guys will tell you if your PSA goes above 0.2, you're going to die or you're going to get in trouble. And that really boxes patients into the scenario that they have to do something, otherwise they're going to get in trouble. When we rolled out C11 choline PET imaging, we decided that one of the first things we would do is we would map out where prostate cancer comes back after prostatectomy. So we were the first group to ever make contemporary maps of prostate cancer recurrence based on visual information using state-of-the-art PET to see where does cancer come back after you have prostatectomy.
oh, I like this.
And our maps showed, beyond a shadow of a doubt, 30% of patients have local recurrence,
Okay.
is where the radiation was going to be given. But 70% of the patients do not have pure local recurrence. They have either local recurrence plus metastatic disease, or they have no local recurrence and they have widespread metastases. So our argument was that, you know, why would you submit yourself to get radiation to the prostate fossa if you only have a 1 in 3 chance of hitting the cancer?
What's a prostate fossa? Is that the prostate bed area?
Yeah, prostate bed, or
Okay.
seminal vesicle bed.
Okay.
So our map said that only 33% of patients are going to have a spot there that can be cured by radiation therapy. And so based on that, we argued that it's better to figure out, are you one of those 33% or are you someone else? And what was surprising was at first there was pushback within our institution. But then when I started sending the patients to the radiation guys saying, well, this guy needs a radiation here and here, they're like, okay, we're good with that. And so now they actually probably do more radiation therapy than what was originally outlined in the old days. Having said that, though, what was interesting was when we wrote our paper, we said we predict that 66% of patients would have recurrence locally and in the pelvic lymph nodes. And then we said if you are on an island and you can't get a PET scan, if you have to get radiation, get it to your prostate fossa and pelvic lymph nodes because you have a higher chance of treating something. And what's funny is they were running at that time a multi-institutional phase 3 study. And indeed, what the phase 3 study told us years later were, yeah, about 66% of people have local recurrence and pelvic lymph node recurrence, and therefore they should get whole pelvic irradiation, not just prostate fossa irradiation. Anyway, we still kind of stick to our guns. It's better to see where the cancer is than to simply start giving radiation therapy if you really want to have a handle on what you're treating.
Okay, then why can't I just get a PSA at 0.3, and if there's nothing there, then do it, then go with Kwon sweet spot 1 to 2. What's the argument against that? I'm not going to get approved for 2 of them. In other words, there's the anxiety. This is like one of the biggest moments of your talk, in my opinion. You outlined the problem. Some folks in radiation are saying you got to get this done ASAP. Your PSA is now 0.3, 0.4. So what about just getting it done, say at 0.4, 0.5, and if there's nothing there, then try again at 1? No, is that bad, or you still are a firm believer? I guess we're generalizing, right? You're a firm believer. Let this thing go a little bit higher so we can see where it is overall.
Yeah, I mean, that is what our practice is. We still advocate waiting until you see it. So, you know, the proponents of early radiation will say, if you go by just the PSA guidelines, you're gonna treat effectively 66% of the patients. But I would argue that of the patients that have recurrence that's treatable radiation therapy, you're going to have a much higher rate of cure if you know what you're treating. Do you understand what I'm saying?
Yeah. Yes.
So we have this constant discussion, and different patients are put together different ways. What people don't realize, and I don't know if you've covered it before, so where did the notion of just shooting radiation at the pelvis come from? That came from Halstedian types of thoughts about cancer recurrence. So in the old days, prior to PSA, the way that we found prostate cancer recurrence after surgery was rectal exam. So a patient would come back and then we would feel something in their prostate fossa and we'd say, oh, there's something there, you need radiation therapy. And patients would get radiation therapy. In the era of PSA, however, not all recurrences are in the prostate fossa. And that's what has changed. What hasn't changed is the recommendation from the radiation therapy side. Oh, you have to irradiate the prostate fossa, right? So I think that, but again, if a patient's stressed out, we have the conversation. We're not going to twist their arm, this is the right way or this is the wrong way. But we will have the conversation. And many of our patients are fine. They say, well, I rather treat something I can see as opposed to run the risk of just giving radiation to a place that the cancer is not located.
So ideally, you still like that sweet spot, regardless of what I'm saying. I mean, you still are a big fan of that sweet spot, ideally 1 to 2, right? I'm not going to change. I'm not going to.
Well, we don't. So when we offer it to our patients, we don't just say, come back when your PSA is 2. Okay?
Yeah, no, I understand that.
We tell them to check their PSA every three months and report it to us. And when we've seen an approximate doubling in the PSA, we tell them, come back and we'll rescan you. Okay.
So if you go from 0.5 to 1, that's a rescan.
Yeah.
So you use doubling. That was going to be my next question. If you use kinetics to help decide when you're going to do the next scan, if whether the rate at which it rises, if it rises quickly or doubles quickly, is more of an indicator that you'll scan again. No or yes?
Yeah, some of the patients, they'll come in and I'll say, well, let's just wait for it to go up a little bit. And they say, how much? And I say, well, approximate doubling. And a lot of these guys have calculated already. They'll say, well, I'll be back in 3 months,
Yeah.
And they're right. And that's when we rescan them. Some of the guys, though, we say, well, come back when your PSA doubles. And they come back in 3 years.
Yeah.
Because
is it archaic? Let's say somebody's negative at their first scan. Let me just give you hypotheticals. I hear the 35 years of complaints about stuff like this. Let's say they're negative at 0.5 or 0.6, and they don't want to wait much longer because the thought process here is, and you know this, that if the PSA keeps going up, the thought process is you're letting the cancer spread further. Can you please, and this is why it's the most important part of my Q&A. Can you address that fallacy or that truth?
So that's, all of this is tied together.
Okay.
So the old way of thinking about cancer was, my cancer is coming back. It's coming back where it was, and it's spreading like wildfire from that point throughout my body. That's the classical paradigm. That's the Halsted paradigm. It's not true. That's why we did the contemporary maps. The contemporary maps show you beyond a shadow of a doubt that once your prostate has been removed, the cancer that is coming back from seeds that were planted at the time of your surgery or even prior. Okay?
Can you please say that again? And also, can you say that again in regards to radiation or HIFU or a focal treatment? Because this is so true. The idea is that it had already spread at the time of treatment, right?
A lot of times when a patient has a prostatectomy, when they have a prostatectomy, even when you get the PET scan, even when you do the MRI, even when you do 5 opinions on the pathology, even if you do repeat biopsies, ultrasound, everything, you say, we think it's confined to the prostate, we're going to remove your prostate. 5 years later, the guy comes back with disease recurrence. Those seeds were planted before the prostate was removed. The cancer did not grow back by the roots right there and then spread to the rest of the body. The seeds are planted. So I tell patients, you're not going to miss a window of opportunity by waiting. The seeds are already planted. We are trying to find out where the seeds are taking root and where they're growing back in your body so that we can come up with a treatment plan that's going to encompass all of these pre-planted seeds in your body.
That is such an important point after surgery and other primary treatment, because you have guys that their PSA will start to rise again. They'll have ultrasensitive PSAs. They'll start to rise again 10, 11, 12 years later, and they'll describe it as my cancer came back. They use the word, my cancer came back, as if it de novo just sprung up again when that seed was already planted at the time of treatment. But the seed was so tiny, it took all those years for it to finally grow enough, proliferate enough, and express enough PSA. Is that correct?
Yeah, and I don't know how many nature shows you watch, but there's these in nature, there's seeds that lay dormant in the soil for 1,000 years.
Yeah.
And all of a sudden, for some reason, they start germinating and they start growing. So with these gentlemen, a lot of times it's not that the seed was so small, it's just that the seed was laying there dormant for whatever reason. And then all of a sudden it acquired the biological signals to actually start proliferating and growing. But those seeds were planted prior to the surgery, and that is the mechanism of cancer relapse, period. No question about it.
I want to talk about false positives and false negatives. I want to show you what I made for you. This is just my chart, but this kind of talks about what you already talked about because it is a growing area of interest. You mentioned the spleen. Why does PSMA go to the spleen? There's a lot of theories why PSMA goes to the spleen. It could be a benign growth like a hemangioma. It could be that it just expresses PSMA. It's an area of a lot of activity, going on, inflammation, lymphocytes. There's a lot going on. So we're learning all this stuff about where PSMA is supposed to go. And I'm fascinated by these false positives and false negatives. So here's a couple of them. I don't know if you want to comment. Ribs and other fractures, those can show up as false positive. You talked about that. Paget's disease of the bone. It's a disease of the bone. You can look it up. It can easily take up PSMA. These bundles of nerve cells in different areas, peripheral ganglia, they call them, that can pick it up. And then there's these post-radiation changes. Some people call it a flare, where you'll get treated, you'll get radiation, and they'll see brighter PSMA, and people think that's a flare, meaning that we shouldn't worry about it too much. But I didn't necessarily want to focus too much on any of these, and I know you can make the list longer today. But do you want to just comment on your talk and where you are with false positives? And is the answer as simple as just make sure you have an experienced reader, or how do you approach this?
It's a difficult problem, and the vast majority of these things, the way we address it is we tell the patient that we'll just have to repeat the scan in 3 months and make sure it's not changing in concert with whatever is going on with them clinically. If a spot shows up that's a nerve ganglion, those are predictable because they're located in certain parts of the body. If a rib lesion looks kind of like it might be something, it's not worth sticking a needle in it because number one, you can't figure out where to stick the needle. Number two, even if you stick the needle in there, you're going to get 50% chance of false negative. It's hard to get tissue out of a bone. So we just say repeat the scan. The only time sometimes it's really helpful to get an additional different type of scan for instance, is if you have a very bright spot inside the bone, if it looks like, wow, this thing could be cancer, this is really scary looking, and then you get an MRI, sometimes there are benign bone lesions that look up pretty bright on PSMA PET scan. But you just kind of have to take it, one at a time, and you have to listen to what's going on with the patient. If a guy got irradiated just three months ago, well, chances are that's inflammation due to irradiation. PSMA PET scan is not immune to inflammatory changes. So someone falls downstairs, someone gets irradiated, someone had recent surgery, someone had recent COVID, someone had this or that. They will light up on a PSMA PET scan. Inflammation lights up. Inflammation is inflammatory cells and new blood vessels being generated.
Right.
The new blood vessels being generated probably make a lot of PSMA. PSMA is not as specific as the name alludes to, because it shows up in a lot of different places, and definitely salivary glands. Definitely, I think the duodenum inside the GI tract. Those are places where you have heavy bona fide prostate specific membrane antigen expression.
So I wonder then, you talked about bone biopsy. If someone's got an isolated rib lesion, for example, and you hit that thing, and if it's cancer, you should be able to kill it. You should be able to get rid of it. Do you just, on the follow-up scan, if it's brighter, do you clearly see changes on a follow-up scan after treating an isolated spot that tells you, wait, that was real or not? Is it just much easier to discriminate after you've hit that lesion with treatment?
The way we typically do it, so if a patient comes in with a PSA of 1.1 and they have a bright spot on the rib and it looks like it fits the clinical picture, then we say, we'll give you radiation to that rib. And then we expect in 3 months, PSA would go down. Yeah. That would be the thing that would be the readout that tells you hit the right thing. So, you have to kind of contextualize it in terms of the overall whatever's going on with the patient.
Do you want me to share with you my favorite Mayo paper in the past 5 years? Because I live in a different world than you do. I had to just share with you because Jeff Johnson was on it, and I never got a chance to tell him, because you never know what can increase uptake from a choline scan or a PET scan. They published a paper in a prestigious nuclear medicine journal in 2021, and they found that increased axillary lymph node or ipsilateral deltoid uptake was occasionally observed in FDG and choline, and they're looking at these other scans performed after vaccination. So in other words, I thought that was really cool. I'm a big fan of, if you qualify for a vaccine, you should get it, but it's another reason why you should be honest with your practitioner when you got a scan. Heck, if you got 3 different vaccines 2 weeks before your scan, at least let your practitioner know, because this area may light up, or the lymph node up here may light up because it's an inflammatory reaction. I thought that was one of the coolest papers, because I'm a lifestyle guy. It was one of the coolest papers that shows you how we're just learning about all this stuff. Anyway, I didn't want to get off track, or I didn't know if you wanted to say anything about that. Okay, so last but not least, I want to emphasize one more thing with the PSMA scan. The PSMA scan, in your mind, when you put together the clinical correlate, shows up negative even though the PSA is really high. It sounds like that's when you get much more enthusiastic about turning to other types of scans. Is that right or wrong?
Can be.
Because I know that you see people who have these numbers that are way beyond the Kwon sweet spot of 1-2, but nothing is lighting up.
Yeah. So that's why we did this study, to see where it will eventually light up. And
Yes.
Many of those patients will actually eventually light up in the lungs or the retroperitoneal lymph nodes. So the reason I did that study is because there are a lot of patients who agonize over the fact that their PSA is going way high, but we can't see the disease. So I was hoping that we could take our large experience and figure out, where does the disease eventually show up? And the vast majority of those patients, it either shows up sprinkled in the retroperitoneal lymph nodes, or in the lungs themselves.
And are those patients, so we know where the lungs are, retroperitoneal, the peritoneum is in the front here, in the back, is the retroperitoneal. There's about, depends on who you want to quote, there's about 40 nodes median on average in the human back. There's a lot of nodes back there, for example. So it has a chance to hide out back here in the retroperitoneum. And you said that part of the aorta, part of the inferior vena cava, all these incredible structures, kidney, and all these nodes are back there. Okay, so it's hiding back here, retroperitoneally, and you find it. Are you still potentially, is the word curable? Can you still knock this thing out?
Again, this is one of those areas where, we created peace with our radiation guys. Our radiation guys will treat patients as long as the disease is below their diaphragm. And they can treat with intent for cure, okay? Especially with the new technologies. So yes, if a patient has exclusively what we think is retroperitoneal lymph nodes below the diaphragm, and we can see it clearly, then we can treat with intent for cure, okay?
Yeah.
Actually, to be honest with you, a lot of this is, I don't, I know that people either probably think it's cliche or disingenuous, or I don't know what they're thinking. I think anyone is amenable to potential cure, period. The only time you don't ever cure a patient is if you don't try hard. If you try things, there's always a shot that you're going to get lucky and you're going to knock the disease out, period. The big surprise with us was when we first started seeing patients with metastases spread through the lung parenchyma. We used to tell people at Mayo, hey, I think he's got mets to the lungs. And they say, no, they aren't. So then we start biopsying them and they say, well, the guy's doomed. The guy's doomed. He's got mets to the lung. That's horrible. And then after all these years, we've looked at outcomes. Actually, one of the best places for prostate cancer to metastasize is the lungs. It turns out patients with lung metastases do better than almost any other subgroup of patient with metastases. That's so counterintuitive. So if we had just listened to what tradition and the culture had said, we wouldn't have been so aggressive. We have tons of guys that we've treated with lung metastases, and they're now 15 years out, and they're doing great, okay?
Yeah.
So, I think that, people are curable until they're not. That's all I can say. And, we try very hard to force the cancer into a corner, to shave it down, to play whack-a-mole until we can snuff it out. We can't guarantee it's going to happen, but we can guarantee if you don't work hard at it, you aren't going to win. Okay?
Do you have any comment on the paper that you did where you said when the PSA is high and it's not being picked up, when eventually it's being picked up by a PSMA scan, it's in the retroperitoneal lymph nodes or the lungs? Are you saying, was there any quantification there? Is this a lung spot? Is it usually you see multiple spots, or was it all over the place? In other words, when you pick it up, do you pick up a lot of volume, a lot of tumor, or you finally just pick up a spot or a few spots?
See sprinkles. You see sprinkles. Yeah. And then, if you see it in the lungs, you need systemic therapy. If you see it in the retroperitoneum, spread around the retroperitoneal lymph nodes, I still treat a lot of those patients with systemic therapy first, because just because you see a couple sprinkles down here doesn't mean that there's not sprinkles up here,
Yeah.
But we have the conversation with the patient.
You call me at 6 in the morning all year long. I hear a lot of your commentary and opinion, so I'm a big boy. I can take it. Is there something else that you wanted to say in regards to these scans, or did we cover most of it?
No, I think that it's gratifying to see that PET imaging more and more and more is being used to treat prostate cancer. I encourage patients to be vociferous about it, to learn about it, and pursue it. We don't want to go backwards in our technology. I don't want to find out 5 years from now that everyone's reverting back to bone scans and CT scans and rocks and twigs to evaluate and treat their prostate cancer.
Yeah.
So I think it's, this is what we envisioned. This is what we wanted to happen when we started back in 2010 and 2012, So I think it's a good thing.
I think it is too. Look, I would tell the audience that I don't know anyone that puts more effort into the lecture. In fact, this guy calls me 6 months before his lecture and starts telling me how it's evolving in his brain. And when we first talked, it evolved in like 8 different directions, and then it eventually evolved into this type of animal. And then he worked on hundreds of slides. And when someone puts this kind of effort, the extensive effort with this experience, we have to give him all the time he wants. So again, I make a joke with him, but we tell him just go. My questions are fun. They're funny at times. They're intuitive. They're introspective, but we instead want the speaker to go. We want to hear all about their experience, which you did again today, and it was brilliant. I really appreciate it. I appreciate our friendship. I've always appreciated how much time you put into these lectures. It's actually sort of stunning. In fact, it convinces me that you have no hobbies. And it's probably explains why you have minimal athletic skills, because you don't have time for athletic skills, but above average in terms of guitar. You're pretty good at the guitar overall. So with that in mind, we got you a gift that's coming to the Mayo Clinic. And again, money is no object when it comes to you, Dr. Kwon. If it's a car, if it's, a puppy, if it's a first class trip to Hawaii, we'll do it. So we thought, no, we don't want to do that. Let's give him something he's never, ever had before that he can use almost every day. You're getting a coffee cup that says, I don't need therapy. I just need to play guitar.
Excellent. And Ziggy played guitar.
Is that the greatest gift that anyone's ever given you?
Oh, absolutely.
Good answer.
Absolutely.
Now, this is my last question. If you did this lecture a year ago at the conference, you could not have provided this much comprehensive education even a year ago. You've added that much more knowledge with your experience of scans plus the knowledge of other papers. So this would have looked very different, in my opinion, not dramatically, but would have looked different a year ago.
Yeah, I think that's true. And I think you bring up one point that's important to bring up. My presentations really don't come from me. My presentations are a synthesis of every single question my patients ask on these visits. So that's where these talks really come from. I try to tabulate all of that. And that's why when I'm putting together these talks, they tend to get bigger and bigger as I'm putting them together, because I'll go, oh yeah, Mr. So-and-so asked about that.
Yeah.
Mrs. So-and-so asked about that. Oh, yeah, I remember that question. So that these talks are designed to kind of answer patients' questions that are very common in the clinic. And that's why I've kind of built these talks this way.
Yeah. Fantastic. See you soon.